It's great to be here. Thank you, Ariani. My name is Noam Harel. I'm a neurologist at Mount Sinai and at the Bronx VA Hospital. I actually spend most of my time up here in the Bronx VA. And we have a pretty big clinical research center focused on spinal cord injury. We do a lot of things up here. Thank you. I'm trying to talk for a minute or two just to give a few more people a chance to join. But we have a large clinical research center here focused on not just trying to improve recovery from spinal cord injury, but we also focus on numerous medical consequences of spinal cord injury. So as many of you know, there are all sorts of bone issues, metabolic issues, skin issues, other lung issues, inflammation issues, and especially blood pressure issues after spinal cord injury. We have programs and studies that focus on all of those things as well. And many of us work with Ariani and Dr. Bryce and some other people at Mount Sinai on other projects, including one we'll talk about today. So we'll give one more minute. And yes, I see a bunch of familiar faces and names there, so hello to you all, and thanks for joining. Definitely don't know all of you, so it's nice to meet many of you. Okay, 2 is my lucky number, so we'll start at 402. Again, so we'll just go. So we're going to talk about spinal cord stimulation today. And one of the take-home points is there are many, many kinds of electrical stimulation. They are not all the same. They are not all alike. So we'll try to distinguish some of the major differences between different kinds of spinal cord stimulation. Okay. And okay. So one of the bedrocks of our whole approach is that even if you have complete spinal cord injury, clinically complete spinal cord injury, where if you have no movement, no sensation below the level of your injury, chances are that you still do retain some spared nerve circuits getting through the injury, okay? So most spinal cord injuries are anatomically incomplete. And this is a picture of an MRI, a special kind of MRI that shows intact nerves in blue. And this is from someone with a clinically complete spinal cord injury. But it just shows there still are some blue axons or blue nerves getting through or around that injury area. Can we maximize the function of this spare tissue to try to improve recovery after spinal cord injury? Okay, so our whole approach is we would love to regenerate the spinal cord damage and make it like new, but we're not there yet. Sorry, we are not there yet. This is someday hopefully going to happen. But until then, we think it's much more realistic to focus on the spared nerve circuits after spinal cord injury, and we call that approach recovery through rerouting, not necessarily regeneration. Can we maximize the function of these spared circuits? And again, the bedrock of our approach is increasing nerve activity increases nerve plasticity. Okay, so the more active your nervous system is, the more plastic, the more likely it is to grow and make new connections. Okay, and good old-fashioned physical exercise is still the best and most popular way to activate your nervous system. So can we target those exercises at the places that need it most? That's a harder task. But good old-fashioned physical exercise, there are drugs that can activate your nervous system. Unfortunately, many of them are illegal because they might be named cocaine or something. But there are drugs that that are in the process of being made, hopefully more safe, that can activate the nervous system in a safe way to increase nervous system plasticity. And we're going to talk again today about electrical and a little bit of magnetic stimulation for the spinal cord. Okay. By the way, I'm trying to make this short, like 40 minutes, so that we have plenty of time to talk about questions at the end. So once again, not all neurostimulation is the same. Okay, there are many, many types of neurostimulation. We're not going to discuss most of these today, but I just want you to be aware. Spinal cord stimulation is not the same thing as functional electrical stimulation. It's not the same thing as tibial nerve stimulation, et cetera, et cetera. There's numerous types of stimulators out there. Most of the ones shown in this diagram are implanted stimulators, but we can also stimulate the nervous system from outside the body as well. Okay. Now here's where it gets tricky. There are basically an infinite number of ways you can apply stimulation to the nervous system. You can apply it magnetically. You can apply it electrically. You can apply it to the brain or the spinal cord. You can apply it to the muscles or the peripheral nerves. You can apply stimulation in pretty much any kind of pattern that you can think of. No, we're not going to discuss these. And no, I don't know them all by heart, but this is just an example of numerous different patterns of electrical stimulation you can deliver. Which one is the best? It's just mind-blowing to think of how you would test all these different patterns in the same person. It's very difficult. You can change the intensity of stimulation. You want to give high intensity, low intensity, medium intensity. Everything can be controlled. Skip that. Those are all things that we can control. What about the person receiving the stimulation? We cannot control who's receiving. Well, we can't control what type of injury you have. You already have the injury. You already are a certain age. So those are your intrinsic characteristics that may affect how stimulation interacts with your body. And we certainly, as the researchers or the doctors, we can't completely control how well you slept the night before, what kind of mood you're in the day you come in. These things have an effect on the outcomes of neurostimulation. So you start crossing these stimulation parameters with all the variabilities from person to person, you start to get an infinite number of combinations. How do you sort through them all? That's something we're still searching for answers, but the general goal is to individualize treatment so that we do find within each person the best combination of this and this to make things work. It's not going to be the same for each person. That's what makes it hard to do the research. And yes, I know that's why many of you are here today. This is epidural spinal cord stimulation. It generates a lot of headlines for good reason, okay? So just to recap, what is epidural spinal cord stimulation? It's surgically implanted, but all things considered, it's a relatively minor surgery, okay? And it's a stimulator, which looks kind of like this. It's relatively flat. It almost looks like a wafer, a thin wafer or cookie that's placed on top of the surface of your spinal cord. It's not placed inside the cord itself. It's placed on the surface above some wrappings that cover the spinal cord. And it's placed on your back, of course, on the back of the spinal cord, not the front of the spinal cord. Okay, so it's called epidural stimulation. And this other contraption here, that's simply the pulse generator. You need an energy source and a battery to generate the pulses that then go to different electrodes on the stimulator. Okay, so what were these? These have been used since the 60s. And you're thinking, well, why don't I have one yet? Well, they've been used for pain. Hold on, I'm gonna see some people in the waiting room. Okay, so these have been used for pain since the 60s. And the way that works is whenever you, let's say, burn your finger or cut your finger, or when an animal has something wrong with its paw, they tend to either lick it or scratch it. And that's called gait theory. There it is, gait control theory. You're replacing a painful stimulus with a non-painful stimulus. And that's basically what is happening here electrically. By electrically stimulating the sensory area of your spinal cord, you're hoping to replace pain signals with non-painful signals. Okay, so I really want to emphasize epidural stimulators are not directly activating motor circuits. They are activating sensory circuits, okay? The epidural stimulator is on the dorsal side or back side of your spinal cord. That's where sensory nerves go in. Sensory nerves go in through the back of your spinal cord. Motor nerves come out through the front of your spinal cord. Okay, so this is your belly button down here. This is your back out here. Epidural stimulators are placed along this side of the spinal cord and activate sensory circuits. However, sensory circuits connect to motor circuits, and that's the key to why we think these epidural stimulators have such a great effect. We're activating sensory nerves, but they're affecting motor circuits. And actually, it's been very well established. There are a lot of motor circuits in our body that are controlled by sensory nerves, okay? So walking, when someone is able to walk, their joints, their muscles, their tendons are constantly sending signals back up. Sensory signals come from your legs up to your spinal cord, and then they connect or synapse onto motor circuits that then head back down to the muscles of your legs. So when the right leg here is planted on the ground while walking, that sends sensory signals up to the spinal cord, and then the spinal cord, you're not thinking about it in your brain. Forget the brain. The spinal cord sends signals back down to your left leg. It's time for me to flex my leg and swing forward. And then when the left leg lands, the spinal cord will send signals to the right leg. It's time for this leg to swing and move forward, et cetera, et cetera. So a lot of motor circuits are controlled by sensory signals. Okay, so again, sensory feedback controls movement. Okay, and it's not just for walking. Okay, whenever you reach for something, you use your eyes. You kind of know, okay, that looks like a tasty cookie. I kind of know how big it is and how much it's going to weigh. When you reach for a jug of milk and you think it's full, but then it's not full, what happens? You kind of grab it and it's a little bit off. The way you can grab, when you unexpectedly grab something that's too light or too heavy, you won't move correctly. And that's a sensory mediated response. You had a certain expectation and the expectation was wrong. It screws up your movement. Okay, but the bottom line again is whether it's your legs or your arms or almost any part of your body, sensory signals control the movement. I think time is going smoother than I thought. I had a baseball related reference here, but I think I already removed it. Okay, but when an outfielder is going out or running after a fly ball, they're not telling their legs where to go. They're watching the ball in the air, and somehow that sensory information from their eyes makes them run to a certain spot in the outfield to catch the ball. Okay. So again, epidural stimulation, spinal cord stimulation is activating sensory nerves. That affects motor nerves. So it's an indirect mechanism. And I'll get in a minute to why that might be better than directly activating motor nerves. Okay, I have a feeling many or almost all of you have heard of Susan Harkema or the University of Louisville. She's the one who kind of made epidural stimulation for spinal cord injury into such a big deal. Okay, now there are other groups working on it, but she started it down in Louisville. So I'm going to show two movies. I believe the sound will work. So before I start the movies, this is a young man. I always forget to look up his exact age, around 26. I think 2 years after a clinically complete spinal cord injury. He had no motor, no sensory in his legs whatsoever, even after intense rehabilitation. He had an epidural stimulator placed, the same stimulator that's used for pain, but they're using slightly different stimulus parameters, and now they're testing his ability to move. Okay, so the top movie is his ability to move with stimulation off. Okay, this is with stimulation off.
Left ankle up, left ankle down, up, left leg down.
Can you guys hear that? Okay, good. Okay, and here now with the stimulator on, what happens? The stimulator is going to be on for the whole movie, but notice he's only able to move when he tries to move. That's key.
Up. Left leg down. Left leg up. Left leg down. Up.
Okay, so again, a few points here. This person has chronic, clinically complete spinal cord injury, unable to move his legs for years, and now he can move his legs. How often do we see that just by coincidence? I mean, if someone has seen that, I would like to know right now. I'd rather not even wait for that, but I've never heard of it. Oh, sorry, Joe. So I believe he had C7 SCI. No, I'm sorry. This is the first person. He had T4 SCI, but many people with cervical SCI have benefited from this as well since then. This is something, it's not normal movement, okay? Not claiming that it's normal movement, but it is incredible to suddenly be able to move the leg at all, even this much, anti-gravity to some degree, after a few years of clinically complete spinal cord injury. So something very important is happening here. And yes, this makes headlines from all sides of the media, okay? So what do we think is happening, okay? When you have a spinal cord injury, remember, we still think there are some spared circuits, but unfortunately, it may not be enough to result in movement. So you're trying to move. You're trying to will your leg to move, but it's not enough to reach that threshold to achieve movement. Now you add stimulation. And really, I want you guys to look to the left of this arrow. The stimulator is on. There is no movement from the stimulation alone. It is facilitating movement once you want to move. Now, volition plus stimulation allows you to reach threshold and achieve movement. Does that make sense? The stimulator is not just, we're not moving you like a puppet. The stimulator is increasing your own ability to move yourself. It's a huge difference. So it's raising the bar closer to threshold so that you, now with that little bit of volition that's getting through a little bit of spared circuitry, you're achieving movement. And really, the best analogy I've heard, I heard it at a meeting. I unfortunately forgot who said it, but it's like a hearing aid for the spinal cord. It's amplifying the residual signals in the spinal cord. Yes, good question. I can't help looking at the chat, even though we're going to talk later. The answer is yes. We think we're bringing neurons closer to the threshold. Anyway, since that movie was the very first person in this series of people that have gotten an epidural stimulator, since that time, that was around 2008. Since that time, roughly 40 or 50 people around the world have gotten epidural stimulators to improve movement after spinal cord injury. And as far as I know, each and every one has regained some movement. Okay, they're not walking around, they're not back to 100%. None of them, unfortunately, are back to 100%. But this has made greater advances than anything else we've heard of. I'm sure we can all agree on that. Nothing else has achieved this kind of advance. Okay, so it's not that simple. I wish it were that simple. What I didn't mention is we're not just turning a stimulator on or off. Each stimulator has 16 electrodes on it. Each electrode can be positive or negative. Each electrode can be its own frequency, its own intensity, its own pulse width. And there you go. Now you have millions of patterns again. And not only does each person need a different pattern, each type of movement or each type of function looks like it's going to need its own pattern. So researchers are still trying to figure out what is the language of this very precise, very complicated stimulation that leads to the best function in each person. That's a lot of work. You can't just put these stimulators in everyone and turn it on. There's no such thing as on or off. There's millions of combinations of stimulation that are going to be required. Unfortunately, that's the huge catch in this. Okay, another huge catch. Remember, this requires surgery. Okay, and to put it very simply, surgery in your lumbar spine, easy. generally an easy thing to do. Surgery in your cervical spine is a little harder and a little more dangerous. Okay, the risks go up when you're talking about surgery in your neck versus surgery in your back. So of course, a big question is, can we stimulate the spinal cord non-invasively? And many of you probably are very familiar with this. This is functional electrical stimulation, where you stimulate, either directly stimulate a muscle or directly stimulate nerves while you're exercising. When the FES is turned on, what happens? Your muscle twitches. You are not in control with your brain over what happens when the FES muscle turns on. So what I'm talking about now is different from FES. We're going to put very similar electrodes. They look pretty similar to this, but they're not going to just twitch your muscles directly. They're going to stimulate the spinal cord. And as David said, they're going to bring your neurons closer to threshold. That's really what we think is happening. So look, these look like FES electrodes. They could be used for FES, frankly, but we're using it over the spinal cord and at different intensity and different stimulus parameters. Oops. Okay, I believe, yes. So, and you can generate movement over, with one electrode, you're generating movement on both sides of the body with multiple muscles from the fingers on up to the upper arms. With FES, you basically need one electrode per muscle, right? So this is a little bit more centralized and we think is going to be more effective. Now, there are pros and cons of using non-invasive spinal cord stimulation, okay? The biggest pro is the same thing as the biggest con. Non-invasive is an advantage and it's a disadvantage at the same time, okay? It's an advantage because it's easy. Non-invasive, we can slap electrodes on you and we can go in a few minutes without surgery, without too much hubbub, okay? Now, the problem with non-invasive is we will never have the same resolution, same ability to target very, very small circuits as we will with invasive stimulation, okay? So it's an advantage because there's no way that millions and millions of people are going to get this epidural stimulator in a year. You can give non-invasive stimulation to millions of people. That's a huge advantage, but there's also a disadvantage too, okay? Nothing's perfect. And just to emphasize that point, this is a figure from the recent headline-making paper from Switzerland. They used a spinal cord stimulator that had 16 electrodes, and they can very finely target different muscles and nerves that are coming from circuits in the spinal cord with this stimulator. Compare that to non-invasive stimulation. That's basically it. I mean, you're just slapping on a big electrode on the back. You're going, hey, how you doing? It's just never going to be as focused as the invasive stimulation. So that's invasive, very focused, hot spots. Non-invasive, we're just saying, hello, spinal cord, here's some electricity. But, okay, so I'm being a little sarcastic about it, but the point is, this, even though it's less focal, we still think that we're activating or bringing the spinal cord closer to threshold. And if we combine that with the right type of volition, with the right type of exercises, that might be enough to work in a focused way. So we're trying to let the circuits be activated by your brain while we use our big old surface electrodes to kind of help get the spinal cord to the right place. What are the risks? We're talking about electrical stimulation here. As I assume many of you have had FES. I can see some of your faces. You can just nod. Does FES ever hurt? Is it ever a little bit uncomfortable? In some cases it is. Not really. Good. Well, okay. I don't want to it's not that painful, I agree. This isn't that painful either, but it can be painful. So by the way, I meant to say surgical risks, which obviously only apply to the epidural stimulator. There's always a risk of bleeding, infection, or inflammation. But these are small risks. I must say, this does not usually happen, okay? But obviously we need to mention them. With transcutaneous stim, now you're sending electricity through the skin. So the electrodes themselves can irritate the skin. Sometimes people have an allergic reaction to the electrodes. So it can cause skin irritation. And yes, there can be pain. Okay, and one other, but again, I agree. By the way, everything we've done or showing here today, we've done on ourselves as well. So we know how it feels. It can be painful at super high intensities, but at most intensities, it's not bad at all. One other risk is, in theory, if someone has a heart rhythm problem, electricity can exacerbate the problem. Okay, we've all seen TV where people say clear and they're defibrillating someone who's having a heart attack. That's actually using electricity in a good way to try to restart the heart. But I wouldn't advise doing that unless someone's unless someone's having a heart attack. So we have avoided so far using spinal cord stimulation with electricity in people who have severe heart problems. Okay, so what's a severe heart problem? Having high cholesterol, having high blood pressure, that's okay. That's okay. Having a history of a heart attack, an actual heart attack, so far we have avoided giving someone with a heart attack electrical stimulation in the past, so far. So might it be safe? Maybe, but we're extra cautious in that case. By the way, yes, FES and TENS, which is still popular today, but doesn't really work. They're all different types of electrical stimulation, but spinal cord stimulation is aimed at the spinal cord, whereas FES is aimed directly at one muscle at a time. TENS is aimed to try to reduce pain, and they all have slightly different frequencies of stimulation. I did want to mention that within this word of inflammation, different from infection, when you implant an electrode inside the body, sometimes your immune system will react to it and cause inflammation that forms scar tissue around the electrode. And sometimes these epidural stimulators stop being able to contact the nerves because there's scar tissue in between them and the nerves. So there's an issue with that as well, surgically. But I want to say I am a big fan of epidural stimulation. I'm not trying to discourage people. I just think more people can get non-invasive than invasive stimulation. So how are we using this at Sinai and VA? Okay, so we'll talk about a few different projects. Okay, so fire together, wire together is a common way to describe Hebbian plasticity. Space there, yeah, he's there. So Donald Hebb was a neurophysiologist, and in 1949, he basically said, if we have a synapse here, a connection between neuron A and neuron B, and we repeatedly fire neuron A in synchrony with neuron B, can we make that synapse stronger? And the answer is yes. Repeatedly firing neuron A and neuron B in synchrony, in locked time, will strengthen the synapse between those two. And by the way, we can fire other nerve connections into the same synapse and strengthen these synapses as well. So this is called fire together, fire at the same time, wire together, strengthen that connection. So we're taking this approach here. We're trying to use brain stimulation with the magnet, which I didn't really talk about so far, and combining it with electrical stimulation over the spinal cord. So you can think of your brain as neuron A and your spinal cord as neuron B. If we repeatedly fire A and B in synchrony, can we strengthen nerve circuits that then head out of the spinal cord to our hand? Okay, so that's my fancy animation there. The hand, that red circle around the hand gets bigger. That means the hand is getting stronger. If any of you are graphic designers, let me know. We can talk about making a better figure. Okay, so repeatedly firing A and B at the right sequence is hopefully strengthening the connection of your brain to the spinal cord and then better controlling your limbs. And we actually have several projects going on. I'm kind of summarizing several projects at once with this slide, but that's one of the major focuses here at the VA. Okay. Now, as I was saying to some of you who were on early, we have a big clinical research center here, a lot of investigators. So one of them is Jill Wecht. She's a world expert on autonomic function. So far, everything I've discussed has been about your somatic nervous system. You know, I want to move my hands, I want to move my legs. That's your somatic nervous system. Your autonomic nervous system controls all your organs. It controls your digestion. It controls your heart. It controls your breathing, essentially. Controls all the other stuff that you don't think about consciously. Okay, so it turns out that epidural stimulation seems to improve autonomic nervous system function. And Dr. Wecht is the leader of this project, where we're trying to apply spinal cord stimulation to improve the regulation of blood pressure. Okay, so I'm sure many of you are familiar with this. If you're lying down overnight and then you sit up in the morning, how many of you feel dizzy or lightheaded? I'm going to guess, especially early after your spinal cord injury, many of you did. Okay, so that's called orthostatic hypotension. What's supposed to happen, whether you're going from a lying to a seated position or from a seated to a standing position, your blood vessels in your legs are supposed to constrict. Okay, they're squeezing blood out of your legs, bringing it back up to your heart and then up to your head. Okay, so the brain senses, okay, I'm sitting up now, blood vessels constrict. But unfortunately, if you have a spinal cord injury, that signal gets disrupted. Okay, this is all autonomic. We're not thinking about this. This is all subconscious. Right, so this is worst problem earlier after injury, as Joseph just said. So spinal cord injury affects your ability to respond to the upright position with the right amount of blood flow. I'm sorry, I'm gonna. Thank you. I will definitely get back to that comment. Okay, we'll continue for now. So anyway, if you just look, we're not going to go through too much detail here, but this is a graph showing that the heart rate up here increases and the blood pressure decreases when someone with spinal cord injury is shifted from the supine or lying down position to the seated position. They get dizzy, their blood pressure decreases, and the heart rate is trying to increase to respond to that. Okay, but they're feeling dizzy here. With epidural stimulation, now there's very little change in the heart rate or the blood pressure. They're tolerating the ability to sit upright. Kind of more amazingly, and I hope it really pans out, is after about 2 months of daily stimulation, now they turned the stimulator off and did the same test. And they're essentially, I don't want to say cured, but they were tolerating the upright position with no effect, no orthostatic hypotension. Okay. So honestly, this epidural stimulation was originally intended for pain. Susie Harkema, she will tell you herself, she originally intended epidural stimulation, let's use it for motor. And then all these unintended good consequences happen. Now we're seeing it has an effect on autonomic function as well. Okay, so there's a big study getting off the ground at Sinai during acute rehabilitation, stimulating the spinal cord repeatedly from the surface. This is called transcutaneous spinal cord stimulation over the lower thoracic spinal cord repeatedly during the time while a person with new spinal cord injury is in the acute rehab phase. We're testing it out to see if it can improve the ability to tolerate the upright position. And since many times during acute rehab sessions, therapy sessions get canceled or aborted because the patient feels dizzy. We want to see, can this improve the ability to not have aborted therapy sessions during acute rehabilitation? So this is part of the Model Systems project at Sinai. This is the main site-specific project going on, one of the main site-specific projects. Okay, we have a collaboration, and I know some of you on this call have been to Staten Island as well. We have collaborations with Dr. Kniku at Staten Island and also Tim Fulverenti down there, where we're using spinal cord stimulation, non-invasive spinal cord stimulation over the lower thoracic area, which is actually hitting the lumbar cord, to try to improve walking. Can we improve nerve transmission to the legs using this technology in combination with treadmill training. Okay, I don't think we have time to talk enough about treadmill training today, but having even someone with no motor function below the spinal cord injury can respond well to treadmill training. And that is because, if you remember, we talked about sensory stimulation earlier. The treadmill will move, and if you're just supported, if your weight is supported while your legs are on the treadmill, your nerves in the legs will send a signal back to your lower spinal cord saying, my leg is moving. That means it's time for my other leg to lift up and swing forward. And that center of the spinal cord is down here. So even if you have a spinal cord injury up here, this area is okay. And your spinal cord itself can start mediating walking-like movements while it's on a weight-supported treadmill. So we're trying to improve that effect by adding electrical stimulation on top of that. There's not going to be one thing alone that cures or significantly improves spinal cord injury. We need to combine multiple things at the same time. So in this case, it's exercise plus electricity. And that's in chronic SCI, by the way. Good. I took a couple of slides out, so now I think we're going to have hopefully a good discussion here. Everything I just did, I just talked about it, but I didn't really do it. So I really want to thank everyone that actually does the work, including today. We had a successful session of one of the fire together, wire together experiments. So I really, really appreciate it. Especially the young investigators here, Linda and Yu Kwang, and our team of coordinators, the current coordinators. Grace is our program manager. Greg, Joe, Kyla, Will is recently departed. Jacqueline recently left, for not departed, but you know what I mean. Went to medical school, etc. These are other past coordinators. Yes, and so I want to make a couple more points. So we have studies going on at Sinai and at the Bronx VA. You do not need to be a veteran to participate in research at the Bronx VA. So our clinical research studies are open to veterans and non-veterans. And our contact information is here, and our lab website is here. Maybe Ariane, I can send this out through you somehow.
Yeah, and I'll share the link via the chat as well right now.
Great. What I really like to do is get to your questions, because I have a feeling there will be a lot, and I need to really read David's question more thoroughly. But let's start with some other questions first. Okay. I will get to that question. Oh, hi, Mary Kate. You're on mute.
Okay, good. Thank you for that really great talk. It was really informative. Can you say a little more about closed versus open loop stimulation, the difference between the two?
Thank you. That's a good question. I actually, I totally glossed over that on purpose, because that's complicated, but that's a good question. So let's see if I can move that. So of the millions and millions of variables that we can control, closed loop versus open loop is one of them. So, and I did not mention that. So closed loop means we can create a system, whether it's implanted or not implanted, a system, let's say an electrical stimulator, that also includes a mechanism to read what's going on in your body and adjust the settings automatically. So let's say it's an electrical stimulator that's combined with a joint angle meter, and it says automatically, when my knee joint bends 30 degrees, I'm going to change my electrical stimulation pattern that way. That's closed loop, meaning the system takes care of it by itself, and we don't have to change the settings from the outside. So open loop is really most of what's happening to date. Open loop means the researcher, because so far it's still research, is changing the stimulation patterns in a certain sequence. Closed loop is, of course, unanimously agreed upon the better choice. but of course it's harder. There's always a catch. I will say the most recent paper from Gregoire Courtine's lab, among many other collaborators, is closer to achieving closed loop stimulation. So can the system read as well as stimulate and change its stimulation? It's like when I recently bought a dehumidifier. So when the dehumidifier senses the humidity in the air and automatically adjusts the fan rate, that's closed loop. Whereas if I had to go down and change the dehumidifier setting myself, that's open loop. So, okay, great. So Joseph's asking about other autonomic functions that I definitely didn't get to. And this is a problem. And in fact, I'll come out and say this is a bias in the field. There are more of us studying motor than autonomic nervous system functions in this field of spinal cord injury. And we do know that people who have spinal cord injury actually prioritize some autonomic functions over things like walking, if you pull a large number of people. And yet the field has been slow to respond to that. So far, most of the evidence is that yes, epidural stimulation does seem to improve bladder, bowel, and sexual function as well, but there are fewer specific scales to measure that improvement than there are for motor effects. And it's a bias in the field, and I'll admit I don't want to admit it, but I've generally focused on motor myself because I don't know how to measure those specifically. So we need to come around and do a better job of measuring those responses. So I wanted to get to David's question. So first of all, I'll get to the first thing. So there's none of this is completely set in stone yet, but I would say I agree with, and I would say the majority of the field has shown in multiple different ways that we do think both the epidural and the transcutaneous spinal cord stimulation is, when you set it at the right intensity, is stimulating sensory nerves, not motor nerves directly. We can show that in several different ways, and we've shown it ourselves. So you can see that the nerve conduction time takes longer than it would if you were stimulating a motor nerve. There's ways to actually measure the difference down to 1 or 2 milliseconds, and we can show it very reproducibly. We can show that if you give 2 pulses in a row, this has been shown both invasively and non-invasive. If you give 2 pulses in a row, and those pulses are crossing a synapse from sensory to motor, the second pulse doesn't transmit as well. If you give 2 pulses in a row and you're stimulating the motor nerve directly, it can keep stimulating all day long. Okay, so in animals and in certain other experiments, you can show that we're stimulating sensory nerves because that second pulse doesn't transmit as well. I know I'm going a little bit into the weeds here or the details, but I'm happy to talk more about that offline as well. Now, you just asked, you heard that it can increase bladder incontinence. Bladder is very complicated. I can't say I've heard that, but I wouldn't be surprised that in some people, maybe it does increase bladder incontinence. So bladder incontinence could come from too much spasm in the bladder. It can come from not enough control over the external sphincter, or it could come from not enough control over the internal bladder wall muscles. So it can be very complicated, and in some people, it might affect one area more than the other and lead to incontinence. It's definitely possible. Joseph, are you asking if it's harder to measure bladder, bowel, and sexual function in animals? That's definitely true. Yeah. Really, one of the best ways I've heard to measure urine output in rats is to basically weigh. I used to do animal research. They live in cages that are full of kind of like a paper confetti-like bedding, and you just weigh that bedding a few times a day to see how much pee is in it. It's not a very precise way of doing it, obviously. Okay, so oh yeah, that's for sure. So yes, this all presupposes a neurologically incomplete or discomplete injury, and that's kind of what we started with. I want to point out again, many people are told your injury is complete. That's a clinical description. Most clinically complete injuries have some intact nerve circuits, and that's what would be called discomplete. Has anyone combined spinal cord and peripheral? Definitely, yes. So probably more people have done brain plus peripheral nerve stimulation. We've done some preliminary experiments ourselves, actually, with spinal cord and peripheral nerve stimulation to see how they interact, but we have not advanced far enough to give that repetitively to look at functional movement yet. I'm happy to take questions by voice as well, by the way. Okay, I definitely need to look up that paper, David. I'm not familiar with that one. So Kelly's asking a very good and very important question. So just to repeat, the epidural spinal cord stimulators that have been used actually were made to treat pain. They were made to treat pain originally in people without spinal cord injury. Now, their sources of pain may be slightly different from the sources of pain in people with spinal cord injury. But yes, spinal cord stimulation might affect nerve pain. But honestly, I have to point out it could increase nerve pain. There's a risk when you increase nerve plasticity. What if some connections to pain centers get strengthened? That could lead to more pain, which we obviously none of us would want. So, and yes, you're pointing out another bias in the field. Dr. Bryce is a world expert on pain after spinal cord injury, but most of us are a little more biased toward motor responses. More of us need to pay more attention to other things, such as pain, bladder function, sexual function. I don't have a great answer for that, except that each person will need, oh, we're on the right slide, so we'll go back to the slide. Each person will need individualized stimulation parameters, and you can change the parameters. So in one person, you might have a certain set of parameters that optimize leg movement. In another person, you might need a completely different set of stimulus frequency, intensity, etc. That might help for pain. So it's a matter of working on both sides to find the right settings. Oh, we can't unmute ourselves. I don't know how to.
Just raise your hand if you have a question and I will unmute you. It's just the security settings are that way. But I can just unmute you if you could raise your hand on the chat.
One of the things, one of the things that our lab has been doing is trying to find other methods of eliciting volitional movement than like lying on a bed or doing the harness of the
Gendrasic and stuff like that.
What did you say, Gendrasic?
Is that what you're?
Oh no, that you made me think of another of another commentary on one of Reg's papers by Werning that said that a lot of these motions could be elicited or confounded by the clenching the person's doing with their arms, which could make it look like it's timed volitional movement. I don't think anybody's directly refuted that in the literature, even though I do think that there is a true volitional component going on. Has anybody talked about that behind the scenes?
Yes. So good question. So we saw a movie of someone moving his leg. It wasn't completely normal movement. And many of you probably know this firsthand. there are some movements that you might make on a daily basis that induce a leg spasm, and you might learn to use that in a semi-functional way. That might not be exactly the same as volitionally moving that leg. I think that's what you're basically asking, right? So can you control a spasm? And it's hard to show the difference, but I do know for a fact, Dr. Harkma has been, raked over however that saying goes. She's been hit hard with that critique. And she and her lab have done numerous experiments to try to show, look, this is volitional in numerous different ways. And the best example I can think of is there was a paper in Brain that was 2014, Angeli et al. I can email that to you later, but Claudia Angeli was the first author in a paper in Brain in 2014, and they have a series of experiments where they follow with their legs, they follow like a metronome, and they can move it, and they change the metronome speed, and they can move at that speed. It seems to be volitional. Okay, let me try to get to, so brain epidural stim. So yes, there was a slide at the beginning of this. There's numerous types of implanted stimulation, and we've all heard of Elon Musk and Neuralink. Neuralink, I'm pretty sure the first goal of Neuralink will not be to stimulate the brain, it will be to read the brain and translate thoughts essentially into computer control. To actually modify the brain with stimulation of the brain in a functional way, we're not there yet. Even Elon Musk is definitely not there yet. The first goal is to read the brain.
Getting there.
I hope you guys could hear me because I don't have my headphones on. It was sort of like a theoretical question because I know they're not using it, but to have the Neuralink device actually send a signal down to like an epidural stim, if that would be a possibility, almost to like bridge the gap where the actual injury site occurs, if that might be better than say like, stem cell where they're actually trying to regrow them, and they can regrow the axons, but they're not really connecting to the right areas. I don't know, that was kind of just my thought. It might be better to jump it, almost like rewiring, than to actually try to repair it physically.
Yeah, thank you. So I didn't understand, now I understand. That's being intensely studied, is using, so that's basically closed loop we're talking about, is can we install a chip essentially in the brain to read the brain and automatically adjust the epidural stimulation to try to help improve function more flexibly. That's being intensely studied, mostly in animals. But I will say the Corteen group, the one with the recent paper that made all the headlines, is studying exactly that as well. You can imagine though the extra layers of safety regulation that will require to do brain surgery on top of spinal cord surgery. But that's being intensely studied, very intensely studied. I see Rolanda has her hand up.
Hi, thank you for joining us. Can you hear me?
Yes.
So my question is regarding the battery and the internal placement of the wafer-like device. Is it possible for people who have less severity of an injury that the constant practicing of like volition and moving your leg, can that somehow result in the ability to do it on your own without the battery or
Activity increases plasticity. So I totally believe if we can exercise enough, or even send the signals down from your brain enough times, that's generating electrical signals descending down to the injury area. That is even more important than the electrical stimulation. The electrical stimulation by itself will not be enough. So we need to combine it with your own body's thoughts and attempts to move. And there was a very famous study, some of you might be familiar with it, done in China with stem cells by Wise Young, who some of you may have heard of. In China, this is a few years ago now, they had 6 hours daily of intense physical therapy, 6 days per week for 6 weeks. Basically, no one in America gets that. Okay, 666 they called it. 6 hours a day, 6 days a week, 6 weeks. And-
6 months. 6 months.
Oh, sorry, 6 months. Thank you. And guess what? They improved a lot, whether or not they got placebo or stem cells. So I think that's a very, very strong statement supporting what you just said. It's hard to do that. Even in acute rehab, it's supposed to be 3 hours a day of acute rehabilitation. And let's be honest, it's not really getting there. There's too many delays in that within that 3 hours.
Thank you so much.
Just a quick answer to Lenore. Yes, it can be done non-invasively as well. The problem is we just don't know it as what we don't know how to relieve pain quite as well as some of the other things. And David, maybe I'll try to get more to you. We'll save the chat and I'll try to respond on email. So I see Ron Gold has his hand up.
I came a little late, so you may have said something, and I did put this in the chat, but I've heard a lot about what Onward's doing and their ties with the Christopher Reeve Foundation. What are they doing that's different than the STEM studies that you and others have been doing?
In one word, nothing. We're all doing something very similar, but it's going to require individualized treatment, I really think. So we're actually, our center is involved in one of the Onward studies of non-invasive cervical stimulation. That's actually a one-size-fits-all approach. Everyone's getting the same, pretty much the same, although even there, it's not exactly the same stimulus parameters. Onward is working on getting an epidural stimulator trial going. They're working with Gregoire Courtine's lab. So they're trying to get that exact thing that was in the headlines recently. They're trying to start a trial in America, possibly this year. My guess is next year. But that will involve implanting epidural stimulators. And then for each person's anatomy and each person's circuitry, finding the set of stimulation parameters that works for them. So they're competing essentially with Louisville, which works with Medtronic. Okay, I will definitely send you that, David. And so Joseph, yes, I do remember you. We could talk offline more. One very frustrating thing about research is every research study anywhere has eligibility criteria. And there's a reason. One of the main reasons is safety. If something is experimental, you have to try to maximize safety even more than usual because you don't know for sure the safety of something. Might epidural stimulation be safe for someone who's had a heart attack? I think it's going to be perfectly safe for them, but I don't know that. I do not know that. And so in theory, it could be dangerous. Yes, thank you, good point, I'll mention that. In theory, something could be dangerous. So there's always criteria or exclusion criteria that can be very frustrating if you have a spinal cord injury or any other condition, and it causes you to not be eligible for a study. So I do want to mention the Louisville epidural studies are now spreading to Kessler up in East Orange, New Jersey, I think later this year. And yes, there's definitely already a long waiting list there. And I don't know how the order is arranged. So it's definitely worth contacting them as well. Maybe I have an answer to that one, but I think I'll send it to you offline. I will say I wish that everyone could share their data in a public database, and that will just lead to these answers more expeditiously. Did I get to everyone's chat? I mean, I really appreciate a lot of questions, but I may have missed some. Okay, yeah, I agree. I've heard great things about ketamine for pain. So I'm all for that. I can't say I know much about it myself, but it's an NMDA antagonist and it seems to be doing great things for pain. So I hope that helps. Any last few questions? No, not all the research, but some people are more collaborative than others. Unfortunately, of course, it should all be collaborative. Believe me, I agree with you. But sometimes not all the data is released quite so publicly. Not. That's a great question and a perfect example of inclusion excellence. So, Josiah, sorry if I didn't pronounce it well. It's talking about multiple sclerosis, basically. Can this be used for multiple sclerosis or transverse myelitis, which is kind of similar? I think those types of lesions might respond the best to this. On the one hand, there's many reasons to say why it should respond very well. And I have a very frustrating answer for you though. Most people in this field are studying traumatic spinal cord injury. And there is a reason why. It's not just random. People with MS, they may have a new lesion at any moment. And so as a scientist, you're scared, well, what if the change in this person's ability is from my stimulation or is it from the disease? It's hard to know sometimes. So people are more likely to study traumatic spinal cord injury where there's one incident and in the chronic phase, it tends to be kind of stable. But it absolutely needs to be studied for demyelinating lesions as well. And I think it will work quite well, in fact. So we do have a big MS center at Mount Sinai. And we have talked, but we haven't really started any research collaborating with them on this. Wow, I'm going to be looking back at this chat and saying, yeah, we got to do this and that. These are great questions and suggestions.
I can send you a copy of the chat if you would like at the end as well.
Yes, please. I think there, I just saved it for myself anyway, but
Okay.
I'll definitely get back to you, David. Many good questions, but and Ariani, I'm happy to share. Please share my. I think I did already, right? It's on the contact information. It's on that slide at the end.
Yes,
happy to take
and
more questions by email, etc.
yes, I also shared the link to your website
Great.
via the chat as well.
Great. Thank you. Thank you, David. Thank you. Thank you.
Thank you, everyone, for joining us.
I really appreciate all you guys watching and asking questions. And please contact me with more. Be happy to follow up. Happy St. Patrick's Day. Wearing a green shirt here. All right. Thank you, everybody.
All right. Bye, everyone.
Bye-bye.
Bye.
Thank you.
Bye. Bye.
Bye.